Thank you, Senator Isaacson and Senator Tester, for having this very important hearing. There's so many good initiatives that we're talking about today. And as we all know, supporting our nation's veterans is one of the most important responsibilities that we do as members of Congress. And I know that you all are working hard to do that also, which we really appreciate. I'd like to talk a little bit about S681, the Deborah Sampson Act, which I'm proud to co-sponsor with Senator Tester and many other members of the committee. It's, as you know, a bipartisan bill that just tries to put much-needed parity to the benefits with our women veterans. As you all point out in your testimony, women are the fastest growing subgroup of veterans, 2.2 million women veterans in the United States, over 20,000 in my home state of Arkansas, which again, we're very, very proud of. The problem is, as we all know, the VA facilities, the VA programs, to some extent haven't changed to a large extent, and we're still living in a different era. In fact, it was interesting when we had our press conference, one of the female veterans, one of the lady veterans talked about being in the VA hospitals, and invariably they would ask if they were looking for their husband. So that's really what we're dealing with. And yet those are honest mistakes, but it's something that we simply need to do away with. So I appreciate you, Dr. Lee, in the sense that you voiced strong support of several of the bill's provisions, to include the pilot program for peer-to-peer assistance for women veterans and expanding the supportive service for veterans' families program. These are really important initiatives, and we're pleased with that. I'd like to talk to you a bit, though, about the opposition to ensuring that each VA medical facility has at least one full or part-time, and I emphasize part-time at least, women's health care provider. I appreciate the VA may already have the authority to make this happen. The fact is that we talk a lot about getting these things fixed, but we truly do hear a lot about the issue that they aren't fixed. And I think that's just a common sense way of stepping out in the right direction. So I really encourage the VA to rethink their opposition to the provision. The bill isn't requiring a full-time provider. The requirement is at least one full or part-time provider. So can you all comment on that?
Senator, as you said, women veterans are the fastest growing segment of the veteran population, and VA is very committed to ensuring high quality care and services for all of our women veterans. We've made a lot of progress. We know now that we have a designated women's health provider at every medical center and almost every community-based outpatient clinic. Those designated women's health providers are trained to especially meet the needs of women veterans and address their post-deployment health issues, and including military sexual trauma. We also have gynecologists at approximately 130 of our sites of care. We have almost 200 gynecologists employed in VA. So we are expanding and interested in expanding that access to specialized GYN care as well. And we think that some of the results really show the investment that we've made. So we actually exceed the private sector in some of our quality outcomes when it comes to breast cancer and cervical cancer screening.
Good.
And
we're going to hold you to that. The other thing, because I'm running out of time, I apologize for interrupting, but the other thing I'd like for you to comment on is I was surprised the opposition to tracking data related to women's veterans. Can you tell me the metrics that are in place now so that we know what's going on, how we identify healthcare needs for veterans currently? And again, a little bit surprised as to why we wouldn't go forward with actually tracking data to give us a better idea as we solve this problem. That's not a new problem. It's been going on for a little bit.
Mm-hmm. So we're very committed to transparency of our data, and what we're striving to do is to use the private sector benchmarks like HEDIS and CAPS, which measure quality outcomes and also patient satisfaction measures like that. In particular, with this provision, our only concern was just the breadth of the applicability to all of our data. In some cases, for instance, in our cemeteries, in the NCA, we may not collect gender-based data, and it could impose some additional costs to be able to do that. So be happy to work with you on narrowing some of the scope of the data collection requirements.
Good. Thank you, Mr. Chairman.